Hello guys, this is Dr. Asif. Welcome back to my channel, that is MRCS Study with me, and also the medical tutorial and surgical classroom. Today this is the last video of MRCS part A, pathology section. So I hope you will enjoy my channels and also and you have seen my previous videos. So let's start. So this is the remaining portion of my notes, that is pathology. So let's start about the important lines and the portions which is important for MCQ. So aggressive fibromatosis means the aggressive fibromatous disorder consisting of desmoid tumors. So it is very popular, that is desmoid tumor related with which gene, that is APC or the adenomatous polyposis coli. So in some MCQ you can see the desmoid tumor. So don't be very panic about the desmoid tumor because it's nothing but APC variant, or most cases are sporadic, not so common. Treatment is surgical excision. Okay, so locally in aggressive manner this kind of tumors and maybe identify both abdominal and extra abdominal locations. Metastatic disease is rare, it's not like so much metastasis occurs here, and also in sporadic manners, not so common, and the treatment is a surgical excisions. Secondly, the hereditary spherocytosis. Yes, in case of January and May 2023, there is one question with the spherocytosis. Okay, so it is one kind of red cell membrane. So which gallstone disease is more common in case of hereditary spherocytosis? That is pigment stone, or due to immature rupture of the red cell membrane. So it is usually came to the MCQ. Okay, now is are prone to splenic sequestration and destruction. Okay, because abnormal RBC will destroy it in the spleen. In that case, splenomegaly occurs. So when a lot of RBC will broke down, in that case hyperbilirubinemia occurs, and also the jaundice and the splenomegaly. These three things will collaborate with each other. That is hyperbilirubinemia and the jaundice and the splenomegaly. So bilirubin level will be increased, jaundice and splenomegaly due to immature red cell destructions. And the older patient with intercurrent illness may increase the rate of red blood cell destruction, resulting in acute syndrome. So what kind of syndrome? Acute syndrome, that is huge jaundice and splenomegaly and also the fever. So severe cases may benefit from splenectomy. In this case, if a huge enlargement of the spleen occurs, in that case splenectomy is suggested. Now the hypersensitivity reaction, it is very important for not only MRCS part A but also the FCPS exam, because in my FCPS part 1 exam I have faced one questions about type 4 hypersensitivity, which is also that cause the contact dermatitis. It is more common in latex allergy, previously latex allergy. In that case, contact dermatitis due to from the gloves wearing in some cases. So I have found a question from type 4 hypersensitivity. So you must know the full diagram here. The description: type 1 is anaphylactic, so immunoglobulin E is responsible, which is exogenous antigenic reactions, and it works with minutes, and the asthma and hay fever is the examples. Okay, now or the anaphylactic like allergic reactions is related with type 1, and it is also called the GELCOM classifications, which is I didn't know before. Now the type 2 is a cytotoxic, G and M is related with this, and antigen antibody bind occurs in the cell surface. It works in hours, and autoimmune hemolytic anemia, pemphigus vulgaris, and also the Goose-Pasteur syndrome. Okay, So this is cytotoxic reaction related activity. Now the type 3, that is immune complex. It is also called the antibody ADCC, that is antigen mediated cytotoxic distractions, which is involved in immunoglobulin GAM and which is soluble and ours and the examples. It has been asked in the exam, that is SLE, serum sickness, Graves disease. Here there is nothing here, but Graves disease also a part of type 3, and also the rheumatoid factors and the Aspergillus fumigatus from the fungus, and also the rheumatic arthritis, reactive arthritis, Graves disease, and serum sickness, SLE. Those all are involved in the type 3 or immune complex mediated, that is autoantibody reaction. Now the delayed or type 4, it is T cell mediated. It works in the tissue factors 2 to 3 days or later, graft versus host reactions, and also the tuberculosis. Here we can also say that our tuberculosis can be here TB, also are examples of delayed hypersensitivity. Okay, now the mimics. So I think you should memorize like that, but when in the exam you have studied a lot of mnemonics, but in that case mnemonics will be crushed with each other. In that case the actual knowledge will diminish. So just try not to memorize a lot of mnemonics, because mnemonics will hamper your normal memory. But to memorize the examples or the types is helpful through the mnemonics, but a lot of mnemonics can also collapse your memory also. Now the Koebner phenomena, it is not so unlikely came to the exam. So it is a skin lesions, psoriasis, vitiligo, warts, lichen planus. These are the examples of Koebner phenomena. Not so important. Now the pheochromocytoma, yes, is very important. That is rule of 10. Okay, there is a rule of 10. 10 cases of bilateral, 10% children, 11% malignant higher tumors is located outside the adrenal gland, and 10% will not be hypertensive. So pheochromocytoma, that means tumor or benign or malignant leoneoplasia in the adrenal medulla. So neuroendocrine tumor of the chromaffin cell. So it is originated from the chromaffin cell at the adrenal medulla. Hypertension, hyperglycemia are often found. So it is one kind of familiar case usually linked to the multiple endocrine neoplasia, that is MEN and MEN2 also, and most tumors are unilateral. Okay, and often right side is smaller than 10 centimeters. So it is usually happening unilaterally. Maximum tumor size will be less than 10 centimeter, not more than 10 centimeter. Okay, so what is the parameters that we will found in the pheochromocytoma? In that case, urine analysis or vinyl mandelic acid. Okay, this vinyl mandelic acid will be elevated, and it will be mimic if the patient will eat vanilla ice cream. Vinyl mandelic acid sometimes raised, but that person is not affected with pheochromocytoma. So this is a false positive records. Now the blood testing of the plasma metapherin levels and the CT and MRI scanning are both used to localize the lesions. Now the treatment will be the medical therapy first, and irreversible alpha adrenoreceptive blockers, that is terazosin, prazosin, alphazosin, and the tamsulosin. These are the alpha adrenoreceptor blockers should be given, and the minority may prefer reversible blockade. The labetalol may be co-administered with cardiac inotropic control, as isolated beta blockers should not be used as the unopposed alpha activity. Okay. So once medically promised pheochromocytoma should be removed. If medical treatment is failed, in that case surgical treatment is mandatory. In that case, most adenolect can now be performed using laparoscopic approach. So laparoscopic approach is very promising for adenolect. Okay, And the incidental adrenal lesions, that is incidentaloma of the adrenal gland, have become increasingly common, and the CT scan of the abdomen is widely undertaken. And so for pheochromocyte also, a CT scan is the gold standard test to identify the staging of the tumor. Also the size, shape, and the local invasion of the tumor can be detected by the CT scan. Okay, so what are the risk factor in this operation, where the IBC, that is inferior vena cava, should be damaged? Laparotomy will be necessary within Satinsky style vascular clump and defect close Prolin sutures. Yes. So as we know that right side adrenal gland is so much closely related with the inferior vena cava. In that case, we should go for Satinsky style vascular clamp, so that adrenal gland will be vascular supply will be affected, but there is no chance of injury to inferior vena cava. Okay. Now the CT scan will show the things which is necessary for diagnosis in tumor or any abnormality in the adrenal gland, like the prevalence rate 75% non-functional adenoma. So maximum adrenal gland tumor will be non-functional. So diagnostic workup is significant lesions. So most of the lesions we through CT we can found less than 3 cm, homogeneous in texture, lipid rich tissue, and the thin wall to lesions. Okay, also thin wall lesion will be thin walled, and the lipid rich tissues and homologous in texture and size less than 3 cm. Okay. Now the investigation: morning and midnight plasma cortisol level. We should know the cortisol level. Dexamethasone suppression test, 24 hours urinary cortisol excretions, 24 hours urinary excretion and catecholamines, and serum potassium and aldosterone and renin levels. Now the risk of malignancy is related to the size of the lesions, and 25% of all masses greater than 4 cm will be malignant. So adrenal gland, if how we can know that the tumor will become malignant? Because if the tumor size more than 4 cm, there is a greater chances. So there will be greater chances, and the almost 25% of all masses greater than 4 cm will be malignant. Okay, so the solution should be usually be excised. So serial CT scan for prognosis, if we want to surveillance the tumor, in that case serial CT scan is done for 6, 12 and 24 months. So all patients with incidental lesion should be managed jointly with an endocrinologist, and full workup describes above. Patient with functional lesion, those with adverse radiological features, particularly size 3 cm, should be proceed in the surgery. Now the glucagonoma. So these are the very rare tumors which is happens in the alpha cell and the pancreatic tissue. So then pancreatic tumors has alpha cells of the pancreas, glucagon markedly elevated. So these patients might cause diarrhea, weight loss, and the necrolytic migratory erythema. Very important. And the serum level glucagon more than 1000 picogram per ml suggests a diagnosis. So how can we diagnose it? That is CT scan is usually required to identify glucagonoma. So treatment is usually surgical excision, and careful staging is required for those who usually malignant, non-resectable. So there are some other glucagonoma. If they are malignant, in that case maximum will be unresectable. That's why CT scan is necessary for making a grading. Okay, now the glioma. Glioma is a CNS tumor which is also called the locally malignant tumor. So typically found in CNS, they arises from the supporting cells of the neuron, that is astrocytes, oligodendrocyte, swan cells, from these. So astrocyte related tumor is more common, which is regarded as a glioma. Okay, glial cell tumor. So they are subcategorized according to the, so ependymoma in case of appendiceal cells, astrocytoma, that is glioblastoma, which is more common here. oligodendroglioma, that is oligodendrocytes, and a mixed oligoastrocytoma. So as you see guys, glioma is originated from the supporting cells of the neuron, not from the nerve cell, that is supporting cells. Okay, because we know that nerve cell, muscle cell is not usually divided. Okay, so the supporting cells are. In that case, if there is any changes or cell division occurs, or repeated cell division occurs, which is uncontrolled, in that case it is the risk factor of glioma also. Okay, the survival rate is beyond 12 months, and the worst prognosis if it is low grade or high grade. So they may be supra and infratentorial. The location is more or like same, tentorial region. And the glioblastoma multiformis has the worst prognosis of a few patients who survive beyond 12 months. So glioblastoma, which is originated from the astrocytes, has a less prognostic factors. Now the thymus, Hassel's corpuscle, you can see here in the central there is a red area. It is called the Hassel's corpuscle. Okay, the hematoxylin and eostain staining. So thymus develop from the third and fourth pharyngeal pouch, very important for embryology. So thymus and parathyroid gland, where that is inferior parathyroid gland and the thymus are originated from the same region, that is third pharyngeal pouch. Okay, it descends to lie anterior superior mediastinum, that is locations, which is encapsulated and subdivided into lobes. These consist of cortex and medulla. So it has a cortex. So this is the cortex, and this portion is called medulla. Okay, and the cortex is composed of tightly packed lymphocytes. The medulla consists of epithelial cells. So maximum T cells originate from the cortical area, and the medulla is usually epithelial cells. So medullary epithelial cells are concentrated, arranged, and may surround a keratinized center, which is called the Hassel's corpuscle. Here the Hassel's corpuscle, and the inferior parathyroid gland also develop in the third pharyngeal pouch that I already mentioned. Can also be located in the superior and the thymus, that is third. So third pharyngeal pouch, from it there is two important organs, that is thymus and inferior parathyroid glands. The artery supply of the internal mammary artery and the pericardiophrenic arteries. So thymus is supplied by the internal mammary artery mainly, or pericardiophrenic arteries. Venous drainage from the left brachiocephalic vein. It is very important for step 1 or the part A exam in case of basic part, that is paper 1. Now the sarcoma. Sarcoma is a malignant neoplasia which is originated from the connective tissue origin, and also it occurs in the bones or the osteocytes. So malignant tumor of the mesenchymal origin, maybe either bone and soft tissue in origin hoite pare. So now the bone sarcomas and the soft tissues. So sarcoma has two types. Some are originated from the parenchyma of soft tissue like muscles and the surrounding tissues, fat fascia, and some portions are originated from the bones. Okay, so those are the originated from the bone. So it's called the osteosarcoma. Sorry for that. Osteosarcoma, Ewing sarcoma, and also the chondrosarcoma. Ewing sarcoma, although the non-bony sites recognized, and the chondrosarcoma from chondrocytes and osteosarcoma from osteocytes. And the soft tissue sarcoma, that is liposarcoma from fat cells, rhabdomyosarcoma from striated muscles, leiomyosarcoma from the smooth muscles, and synovial sarcomas from closed joint. Okay, the malignant fibrous histiocytoma is the sarcoma that may arise from both soft and bones, soft tissue and bones, which is very worst than prognosis. And malignant fibrous histiocytoma is a massive tumor which goes very rapid and through the hematogenous route spread through. In that case, we should diagnose early and excise the part of the bone. So certain features, that is mass and swelling, should raise suspicions. So it will occur as a large, more than 5 cm soft tissue mass, deep tissue located in intra and intramuscular locations, rapid growth and painful lump, so the lump will be painful and rapid growth. So imaging suspicious masses should utilize a combination of MRI, CT and USS. Okay, that is ultrasonography. So blind biopsy should not be performed prior to imaging, where the record should be done as in such a way that biopsy tract can be subsequently included in any resection. So if biopsy occurs, in that case during resection you have to take out the whole margins of FNAC port. Now the Ewing sarcoma. So Ewing sarcoma is more common in male, in case especially young males. Incidence 0.3 to 1 lakh, so it is less common. Onset typically between 10 to 20 years of age, so common age. And the femoral diaphysis is common sites. For histologically it is small round cell tumor, and blood-borne metastasis is common, and chemotherapy is often combined with surgery. So I saw in the hospital a case that is 22 years old female, which has a very large tumor here in the shoulder joints including. So in the biopsy or histopathology and all including immunohistochemistry, we can see the round cell tumor and also called the histiocytoma, that is Ewing sarcoma. So it is mainly femoral diaphysis occurs, but sometimes in case of large tumor shaft of the humerus also affected. So it is also called a long bone. Not only female is a long bone, but also humerus also affected with the same kind of problems. Now the osteosarcoma. Osteosarcoma, mesenchymal cells with osteoblastic differentiations. 20% of mailing to all primary bone tumors. So it is about 20%. So in the exam there is a question: what is the most commonest bone tumor that is metastatic carcinoma? Most commonest bone tumor, and what is the most common primary bone tumor, and that is osteosarcoma. Okay, these two things is sometimes mimicking with each other. And the peak age is 15 to 30, commonly in males, and osteosarcoma may complicate Paget's disease of the bone up to 10%. So osteosarcoma may complicate Paget's disease. Okay, which is so near with each other. In that case, limb preserving surgery may be possible if many patients will receive chemotherapy. Okay, so here you can see you have to identify the tumors here, that is osteolytic lesion present and the irregular margins with soft tissue originated from here, and you can see the Codman's triangle and sunburst appearance here. This is a Codman's triangle. So this is the Codman's triangle. So here the Codman's triangle arrow, here the Codman's triangle. Okay. Now the liposarcoma. Liposarcoma is sarcoma from the adipose tissue, which is a malignant adipocytes. 2.5 in 1 lakhs, and they are the second most common soft tissue sarcoma. In my clinical careers, I haven't seen anyone. Okay, and typically located deep locations of the retroperitoneum, affect older age group more than 40 years of age, may be well differentiated, thus slow growing, although may undergo dedifferentiation and disease. Okay, many tumors will have a pseudocapsule. So there are many tumors which can misleading, allow surgeons to feel that they can shell out these lesions, and in reality tumors may invade the edge of the pseudocapsule resulting from the local recurrence. So this liposarcoma can also what recurrence. Okay, may have a recurrence. So usually resistant to radiotherapy. So these are the resistant, also often used in a palliative setting. So liposarcoma fate is not so good. It usually occurs in the more than 40 years, and which is differentiated and slow growing through. So you have a lot of time to diagnose and excisations. But if the time exceeds, or if the patient came with later age, so there will be less chance of total cure or excisions, so that will be palliative setting. So tumor with large number of histiocytes, most common sarcoma in adults, okay, malignant histoma. Undifferentiated pleomorphic sarcoma, cell origin is not known. 4 major subtypes are recognized. Storiform pleomorphic, myxoid less aggressive, 70% is storiform pleomorphic, myxoid less aggressive, and giant cell and inflammatory, okay. So treatment is usually surgical resection and adjuvant radiotherapy, as they reduce the likelihood for local recurrence. So as you know that malignant fibrous histiocytoma is so much common as a sarcoma. I have seen 2 patients in my hospitals, and our fellow professors is cut down the portions, okay. Now there are some parasites which is surgically important. I'm going to discuss it about it. That is Trypanosoma cruzi. It is also protozoa. It's called the Chagas disease, and they carry the bugs which infect skin through feeding. Penetrate through the open wounds and mucous membrane, and intercellular proliferation occurs. The major site of action is CNS, intercellular mesenteric plexus, causing similar to achalasia. So lower esophageal sphincter or the smooth muscle is affected. In that case, this is difficult to relax the sphincter. In that case, this is called the achalasia. Spleen, lymph nodes, and cardiac muscles is involved. Chronic disease is irreversible, and Nyferti marks is used for treat action. No need. You must know that Trypanosoma cruzi causes Chagas disease is also a protozoa originated from, and the affected mainly CNS and intestinal mesenteric plexus. Now the actinomycosis, yes, is one of the important parasites which is more common in Africa. In that case, there are multiple sinuses occurs here with granulomatous infection. So it is a chronic and progressive granulomatous disease, filamentous gram-positive anaerobic bacteria from the Actinomycetoma family. So actinomycin commensal bacteria becomes pathogenic when mucosal barrier is breached. It is also called the Madura foot. In case of leg or cup muscles, it is called the Madura foot, which is also occurs by actinomycosis. The disease most occurly in the hand, neck, throat, also abdominal cavity, okay, and the thorax. The mass will open, enlarge the cross tissue planes, and formation of a multiple sinus tract. Very important. I have already told you that multiple sinus tract. Now the abdominopelvic actinomycosis occurs most frequently in individuals has appendicitis, 75% cases. So in case of say appendicitis, there are some 65% cases also happened by the actinomycosis. So what are the sign symptoms? On histological level, gram-positive bacteria, evidence of sulfur granules, very very important. Sulfur granules may be found, yellow sulfur granules, and the facial flushing. And the colonies of the organism appear round, oval, basophilic masses, and also seen other like narcosis. So in this kind of patients, you can see facial flushing here. And the long-term antibiotic therapy will be penicillin, and the surgical resections is indicated for extensive necrotic tissue, non-healing sinus tracts, abscesses, while biopsy is needed to exclude malignancy. So it is very very acute looking and aggressive. There is multiple sinus tract present in surrounding areas, which is happened due to the actinomycosis, and also there is a chances of presence of malignancy. So we must exclude the things. Now the burn is a surgical conditions. It will be discussed in the burn chapters, and I hope you like my channels. And this is what about the ending of the pathology sessions. So I think you will like my channels and subscribe and continue to watch my videos, so that you have a good basics for MRCS part A especially, and not only that but also the FCPS part 1 exam, because recently I have passed FCPS part 1 and MRCS part A. So I think you should continue watching these videos. So those are always free free of cost. No, there is no need to take any courses regarding that, because you have to know that if MRCS part A exam patterns is just day by day changing. So in upcoming sessions you have to know that no questions will be repeated in few days, in few attempts. So all are the new questions will come out through the exam. That's why you have to build your basics first, and then you have to practice EMRCS for knowing the patterns. But just go through the EMRCS question explanations and also watch my videos. You no need to take any courses, because those are costly. Also, you know that part A question is also costly and also very time consuming. Thank you very much for watching. Thank you very much for like my channels and subscribe. Thank you.